big part of the nutrition chapter is weight gain, etc., which we already covered. So other than that, as far as nutrition, even if I didn't tell you anything, you'd probably be able to answer the questions. And anything that I do will be in that recording, okay? So I think you'll be okay with that, but I really do want to talk to you about the rest of this chapter, and I really would like to talk to you about chapter 15. So I can usually do chapter 15, the whole lecture, in an hour, and I think tomorrow we'll have an hour. So if we don't get through it, don't panic. I really do want to talk to you about it, though. And you'll want to record it probably because somebody just told me today, forgive me if I can't remember, but maybe I do now, looking over the sea of faces, who somebody might have to leave a little early tomorrow for a, very personal reason that you don't need to know about. Okay. So anyway, I don't want you to panic. Is that okay? Okay. We really do not want to panic. What is it Miss Henderson always said? Deep breathe? No, it isn't.
Oh, you Mrs. Spindler.
What does she always say to tell you to relax or?
Woosah.
Oh, that's a new one. Okay, all right. So let's go on through the antepartum assessment. Other than assessing all of the histories that we talked about, the EDB, the TPAL, and all of that, there will be a physical exam that will take place. The registered nurse even will not do any of that except for vital signs and the height and weight, usually. Okay? Advanced practice or a healthcare provider will be the one to do the physical exam on the patient. So just knowing that we do a physical exam, including speculum exam and that kind of thing, is really all you need to know because you're not going to do it. Okay? There are some labs that will be drawn or collected on the first visit and maybe after that, but the ones that are listed are definitely going to be on the first visit, and it really is coming. Yep, there it is. So the labs are going to be type and RH. This is going to be a whole lecture later. There's also a handout posted in Canvas about type and RH. Very important for the registered nurse to understand type and RH. I know you did when you had one of those A&P classes, but if you don't now, we are going to learn it. I don't care that you're not going to work at OB. You need to know what type and RH means. And I run into nurses all the time who don't know. I want you to know. And if you get to be a registered nurse and you forget something, I want you to go back and read it and not be one of those not knowing people. Because it's basic physiology that we all should have an understanding of, okay? So we're going to do their type and RH. As we get farther along, we'll find out why that's really important. But for right now, we don't really need to, I don't think. Also a CDC, a rubella titer, which will tell us whether the patient is immune or not to rubella. If they are not immune to rubella, do we give them a vaccination of rubella during pregnancy? No, we do not, because they could possibly get rubella, and then that would not be good. Sexually transmitted infections include VDRL and RPR. When you're looking on the chart, the reason that there's a slash mark here is because they are what? They're the same thing. They test for syphilis. They're a screening test for syphilis. If this comes out positive, then a more specific test to actually identify the spirochete will be done. But these are exactly the same thing. I used to get care plans and students would write VDRL negative, RPR negative. I know they didn't get it off the chart because nobody has them both. Insurance companies won't pay for that. Why would they pay for the same test? They don't. Okay, so just know these are the same thing. Screening test for syphilis. HIV. If you remember, HIV testing is a law in pregnancy, right? And how does the patient, do they decide to get in or get out for their HIV? Get out. You and I, as non-pregnant people, we have to opt in, meaning we have to sign a consent. They have to opt out by signing consent. The whole idea is the easier it is, the more likely you are to do it. Okay, and we want them to do it. And Hep B, of course. Well, never mind. Okay, Pap smear, Group B strep testing. We'll talk more about that later. If you don't know what it is, just now know it's there. Genetic testing if needed or desired, a UA and a PPD. And I feel like there's something missing from that, but if I think of it, I'll let you know. Okay, here's a question. First prenatal visit, blah, blah, blah. So maybe somebody, did you erase your beautiful picture over there? You did. Notice it's just asking for gravida, para, and abortum. There's no TPA on it. Joe, pass it on my little circles. If you didn't, you pass on the end. What do you think the answer here is?
Just one.
How many times has she been pregnant? She's at the prenatal clinic. She's pregnant. She had a baby boy 9 years ago. She was pregnant. She had twin girls 5 years ago. She was pregnant then. She had a miscarriage. She was pregnant then. She was pregnant 4 times. So now you can narrow it down between the first one and the third one. Let's see. Can we tell by aborta? She had a miscarriage at 9 weeks. So both of those are 1. Nope, we're going to have to figure out the paras. So when she had a 9-year-old born, was that a para?
Yes.
Yep. And what about the twin girls? How many paras was that? One para.
Oh, one.
One para. And then the miscarriage doesn't count. So it's first one, gravida 4, para 2, aborta 1. Remember, the para just counts the delivery of the pregnancy. It does not count the individual fetuses. That's the TPAL.
So the boy, the twin girls, that's 2.
Right? Okay. Obviously, this is important because I keep saying it over and over. It's important because I'm going to put a couple of questions. I know they're on the, only because students tell me I've never read it, but on the HESI. And I know it's on the HESI practice test, though, so I assume it could be there. So what else are we doing? Now, that's all your first visit. Look at all the things we're doing during the first visit. All the history, the GPTPL, all that stuff, and the physical exam. And then they go home with a bag about this big, full of all kinds of information and educational stuff, and free samples, and blah, blah, blah. And then what do? Well, here's a list of subsequent visits and the frequency of those based on a normal risk woman. Okay? A real list would be prepared individually for each person based on their risk. This is a normal risk person. So during the first and second trimester, we would anticipate seeing this woman every 4 weeks. But in the third trimester, beginning, at 28 or 29 weeks, through the 36th week, we'll see her every 2 weeks. My daughter-in-law, who was high risk, began at that week going twice a week. Okay? So high risk is going to go more. She had an NST on Tuesday and a biophysical profile on Thursday every week. So that's what they do for high risk usually. 37 weeks to birth will be every week. Again, she was going twice a week, sometimes 3 times a week, depending. Okay? So this is a normal risk person. So what do we do and when? This is what we do and when. Every single visit. Boom. Specific times. Every single week, we're going to get our vital signs. Every single week, we're going to weigh them. Every single visit. Every single visit, we're going to dip their urine. What are we dipping their urine for? Protein, which might mean preeclampsia, which you might not know, but we're dipping it for everything that could be abnormal, which would be protein, blood, red blood cells, albumin, white blood cells, glucose, oh yes, glucose, right? We're going to measure their fundal height every visit, beginning when we can palpate it. I believe your book might say we begin measuring their fundal height when the fundus, when you're 20 weeks. And where's the fundus at 20 weeks?
Umbilicus.
At the umbilicus or the umbilicus, either one. However, a nice thin woman, you can feel it before then. Okay? If they're fluffy, it might take that long before you can actually feel it. Okay? So we'll do that every visit. And fetal heart tones every visit. Now, we're going to ask about signs of labor. Probably later on, second trimester. Doesn't really say specifically. An ultrasound at 20 weeks for a normal risk woman who's had no bleeding, no prior history. That's just a normal risk person will have an ultrasound at 20 weeks. Why 20 weeks? That's why the patient thinks we do it at 20 weeks, is the gender. Why do we do it at 20 weeks?
Make sure there's no abnormalities.
Because all the pieces and parts are in place at 20 weeks. They're growing in function, i.e. their kidneys are, filtering better and getting better, but all of the anatomical parts and pieces are present. Now they will just grow in effectiveness of the function of those organs and in the size. But at 20 weeks, everything should be there. But what most parents are looking for is the genitalia, okay? Glucose screening for a normal risk woman. What the high risk is, woman, we'll talk about when we get to that chapter. So this is all normal risk. We'll do glucose screening at 24 to 28 weeks. We'll get into details about that. This should be in your notes, though, no?
No.
Seriously?
No, that's not.
My
Like that
Lord,
little
you're gonna have
part
to
right
write it
there,
all
the
down.
table, it's not in here.
Oh, well, I made the table up.
Is this PowerPoint available somewhere?
Hmm?
Is this PowerPoint available?
No, it's
Canvas?
on there.
It's in the labo.
You really? How about you just take a picture? Last semester, I had a lot of Shutterbugs in here. I tried to photobomb a few of them. Okay, ISO immunization has to do with the RH. So just know that we're gonna do something about their RH at 28 weeks. We're gonna check them, okay? Pelvic exams will be done on the first visit, but if you're not having any problems, there's no more pelvic exams, no digital vaginal exams, no speculum exams until the end of pregnancy. If you're a normal pregnant person. It's the first visit and then the very end. So look at what we do on every visit. That's what occurs most of the time. Some women think, God, why do I even go? I don't even do anything. Take my blood pressure, weigh me, ask me if I have any problems, and get my urine, and off I go. Well, because with all of that information, we can detect, and listen to the fetal heart rate, we can detect problems with mother and fetus early on, just from normal weight gain, normal vital signs, or not. Fetal heart tones, measuring the uterus, and all of that information gives us complications of diabetes and preeclampsia, fetal demise, just all kinds of stuff from very simple stuff. The weight, the height, fundus, whatever else it says up there, Now, when we measure the fundus in terms of weeks, we take a tape measure. She is laying supine, but only for a short time. Put the 0 on top of the symphysis pubis. Again, that's a bone, so you have to feel there. It has nothing to do with pubic hair, okay, or the mons pubis at all, whether there is any or not. So, feel of the bone, okay? Put the 0 there, and then stretch it all the way to the fundus. Notice they didn't stop right there. She's pushing her fingers down, and she's going to feel the top. This is not the top of the uterus. What is that? It's the anterior part of the uterus. This is the fundus, the top. Fundus means top. So we want to feel the top, not just the front. So you have to push your fingers down in there, and then you're kind of tapping it on the front like that to make sure that's where it is. Okay, it can be a little uncomfortable, depending on how fluffy they are, okay? So that's how we measure it. Now, what do you say if we measure a mom who's 22 weeks and we measure her fundus at 20 centimeters, because every week equals a centimeter. So she's 22 weeks gestation and measuring 20 centimeters. What do we know? That ain't right. What do we need? More data. Again, it's not for us to figure it out. I can tell you, it could be the dates are wrong, could be the fetus is not growing, could be a lot of different things, but all we need to know as the registered nurse is, that ain't right. That's reportable. We need to report that, and more data needs to be collected, okay? I'm going to get to that in a minute. Megan, you're assigned to tell me about that, okay? Is this the one we already did? Did you already look at 258?
Yes.
Okay, I thought so. Right, that's already the one, the box. Because what we're going to be doing during the antepartum time frame is we're going to be teaching. You notice a lot of that, we're not doing the physical exam. I mean, yeah, you might draw some blood, but a lot of what we're doing is teaching the patient. We're teaching them health style, health behaviors, lifestyle. We're teaching them what's normal, when to call us, you know, and that's a really big thing. You have to be very firm with your patients to call you. Because when they wait and wait, well, it's 4:30, I know they're still sleeping. Oh, 4:30, I'm gonna wait till 6:30 or 7 maybe, and then I'll give them a call. If they're having contractions from 4:30 to 6:30 and they don't call you till 7, whoa, they're probably already moving on in labor. They need to call us. They don't want to call and wake up a healthcare provider. I assure you from taking call for 8 years, they have no problem calling their specialist. When they looked at our calls, how many calls I got every night, how many calls the doctors got, mine were 10 times as big as theirs. Because nobody cares if they wake up a nurse practitioner. Everybody wants to not disturb the doctor. Nobody wants to anger the doctor, even the patient. But you have to tell them, whatever your policy is. It might be to call labor and delivery, if the hospital you're going to deliver at. Go to triage with the hospital, call 911. But you must encourage them, order them, give them permission, beg them. If you have these danger signs, you must call us. Don't wait to call us in the morning. It may be too late. Okay? So very important. Okay, so here are some influences on pregnancy. Who psychologically, where do these influences, how is the mother going to react psychologically to pregnancy? What kind of depends? What depends on that? If it's planned, unplanned, wanted or not wanted, her support system, age, culture, marital status, safety, absolutely. Everything, okay? So all of that. Whether this was conceived by sexual battery or not, maybe conceived by a partner who has now kicked her to the curb and moved on. You think that doesn't happen, it does. Maybe a partner who was murdered during pregnancy. I mean, a lot of things, everything in her life is going to depend on how she's psychologically best to this. Now, Mr. Rubin, or Dr. Rubin, has 4 tasks that he established with the maternal role taking. So you can look in your book, and I don't have these memorized. You see, that came in 1984. I graduated in 1978, so I never learned that in my basic nursing course. So I know it's having acceptance of their child by the community, acceptance of their own self as being pregnant, whatever. I'm not going to ask you a question on it, so if you want to read it, but I'm not. But how a mother reacts to pregnancy, the very first feeling or emotion that mom usually has, and this is pretty regular, is they're ambivalent, which means they're unsure. Remember, they got hormones going yin yang all over the place. So one minute they're like, oh, I'm so happy, I'm blessed, I'm having a baby. Oh no, daycare's so expensive. What was I thinking? Oh, it's going to be so cute. I hope it's as cute as his little brother. I love him so much. Sonia just said she loved her 3-year-old so much. 5-year-old, sorry. So, but they're up, they're down. They got the rash. They're peeing all the time. They're nauseous. Their breasts are killing them. They're a little ambivalent, a little touchy-feely. They cry at the little and nothing. And what is the dutiful partner, whether it be a man or a woman, it doesn't matter, standing by? Want to help them, soothe and take care of them, and fix everything. And you know what she's saying? Don't touch me. Back off. I gotta go here. Get all here. Zen myself. So seriously though. So what I'm telling you is, we think they love each other. You you date, you get married, you love each other, you have a baby, everything's lovey-dovey. Not so much, because we have a lot of emotions going on in pregnancy. And if there are marginal things happening, such as you mentioned safety, if there's any marginal issues with safety, violence, verbal abuse, what we see in pregnancy, increase. If they're already verbally abusing, much more likely for physical abuse now. Because remember, abuse, if you don't know, is all about one thing. Power and control. The boy has this partner, lost power and control now. Because there's something going on in here, they got nothing to do with that. And everything gets ratcheted up. Put all that in there, plus all the worries of taking care of a kid, paying for a kid, you know? All that weighs very heavy on some people. Some people, they don't care if they got 2 nickels to rub together. If they don't have a baby, by golly, they're getting it. My husband said when I wanted the second one, and the first one was 9 years old, are you sure? For one thing, there's your age we have to worry about. He said, but then, what about the earth? Is it good for another person? What about the pollution of the water and the air? Well, is it right to bring another body into the world? I'm thinking, my hormones are raging, and I got to get on this right now. Like, what are you talking about? Well, I just don't know. It's such a big conversation. I'm like, no, not really. So I'm just saying there's a lot of stuff going on. So the reason I'm telling you this, and I say it in a way that I want you to remember it, is when you're with other people as patients or clients or family members, keep your happy face on, like, oh, everything's happy, they're in love, they're having a baby. But keep your little antenna going, looking for anything that doesn't look right, okay? Controlling, power-hungry people, partners, again, hetero, homosexual, doesn't matter. They will be on this woman like white on rice. And you won't be able to have a word with her without that person there. And sometimes before, if you weren't cynical like me, and I'm telling you, you'd be like, that's so sweet. They come to every appointment. Even she just had a blood draw and they came. I can't believe they like took the day off. How do they do that? Well, they come so that you can't talk to them. So you can't slip something in their pocket. Okay? Now, who's going to get abused? Anybody. I know a midwife at Tampa General. I don't know. She speaks of this publicly. She was one of my co-workers at the crisis center, and when I first met her, I didn't know this. She didn't talk about it publicly for a while, but she was physically abused by her husband. If you met this woman, she makes me look like a little purring kitty cat, because she is not big like me. She's tall and slender and very accomplished, a midwife for 30 years, and if you thought, God, could anybody push her around? You'd be like, no way. Yes way. Because she will tell you, powerful people are very manipulative and they're tricky. Okay? So I'm telling you, it can happen to a woman driving up in a Jaguar or a Maserati or whatever, just like it can happen to one riding the bus. No boundaries. No boundaries. Okay? So we have to look for the signs. And one of the things we do is we ask, are you safe? Now, you have to be careful because you can't be sticking little things in their purse or making secret appointments with them or whatever, because as soon as that abusive person finds out, they are going to be on them. And they might kill them this time. So we have to be very careful. The only thing you can really do is to let them know that you're there. And when they are ready to make a move, they can call you and you'll do it. But you've heard the stories. They have to hold away money because they have no money. The other person's in control of the money. Okay, so have to be careful. One other situation I've seen in the past 15 years, rivals, and I'm just saying this, and just take it for what you want, don't even look at me, rivals pregnancy in terms of escalation of domestic violence. And that's being in nursing school and getting almost done. Because the person who's likely had power over a nursing student in terms of the money gives you power, whether you like it or not, it gives you power. And they now see you, the nursing student, getting near the end, and you're going to be able to go, see ya. I got my own job. I'm not kidding. I can tell you, even last semester and the semester before, specifically, these things happen. I tell you because don't be ashamed. Pam used to be ashamed. She is no longer ashamed. She realizes she needs to tell people. This happens to all of us, even us educated, powerful women and men. So be aware for yourself and your family and in pregnancy, and especially as nursing students. Because they get real nervous when y'all start getting all sort of puffed out there, you know. I'm going to make it now. Just see.